Upper respiratory disorders. The average person will develop 3 to 5 upper respiratory infections annually that have the potential to develop into more serious infections. One of those issues would be rhinitis, and this is also known as the common cold. It is basically an inflammation of the nasal mucous membranes. This can be acute, chronic, or can even have an allergic basis to it. It's most commonly caused by the rhinovirus through inhalation or contact with contaminated items. Allergic rhinitis would be caused by a hypersensitive reaction to some allergens. These clients are going to have sneezing, nasal congestion, rhinorrhea, which is a clear nasal drainage, sore throat, watery eyes, cough, low-grade fever, headache, aching muscles, and malaise. We're going to treat it with antipyretics, decongestants, antitussives, saline gargles, saline spray, antihistamines for the allergic rhinitis. We should also educate the clients on prevention and minimizing potential complications. Hand washing. With the gerontologic considerations, we need to be aware that rhinitis can potentially be serious in the older adult, and they should seek medical assistance if their symptoms do not resolve within 7 to 10 days or their breathing becomes compromised. We should also provide client teaching on over-the-counter or steroid medications, as they might have some undesired side effects. Now, something that a lot of people are not really aware of is our nasal sprays can actually increase blood pressure. So we need to be cautioning our clients to use this sparingly. In addition, it can have what we call rebound congestion. So once the medication wears off, then they are like doubly congested because of the rebound effect of that medication. Sinusitis is also known as rhinosinusitis. It's an inflammation of the sinuses and is classified according to its duration. It will occur most often in the maxillary sinuses. These clients will experience headache, fever, pain over the affected sinus, nasal congestion with a postnasal drip, and that could lead to a cough as that drainage goes down the back of the throat and collects, and pressure around the eyes. We treat it with saline irrigation, not your saline sprays, which might be effective because we like to keep things moisturized. I'm talking irrigation, which would be like your neti pot, where you're actually pushing fluids into the sinuses and then they're draining out simultaneously. Antibiotic therapy might be required, vasoconstrictors, and nasal corticosteroids. Surgical management can be done for chronic sinusitis. They can do the Caldwell-Luke procedure and an external uh, phenioethmoidectomy. They're going to be more of a radical treatment to help remove diseased tissue and alternate drainage openings. Postoperatively, it would be very important for us to observe for repeated swallowing. If they're swallowing a lot, this can indicate maybe there's some bleeding going on down the back of the throat. Optic nerve function assessment. Monitoring the temperature every 4 hours. Pain over the involved sinuses. We can administer analgesics every 4 hours if necessary. Um, Maybe doing some ice compresses. Nasal packing and addressing under the nares. This is what we call the mustache dressing. We would encourage the client to avoid straining or blowing their nose for up to a couple of weeks. We would also encourage mouthwashes, humidification. We want to keep those mucous membranes moist, increased fluid intake, nasal decongestants, and antihistamines as prescribed. And nutritional recommendations would include increasing vitamin C and zinc at the start of symptoms. Which of the following statements made by a client with sinusitis would indicate to the nurse that further teaching might be required? I use a warm mist humidifier at night. I take my decongestants when the doctors ordered them. I will call the physician if my fever comes back. I will put ice packs on my sinuses 3 times each day. And that's going to be, I'm going to put ice packs on my nose 3 times each day. Pharyngitis is frequently associated with rhinitis or other upper respiratory infections. It's inflammation of the throat, and it can be caused by viruses or bacteria, group A streptococci or strep throat. This is going to be the most serious, and it can actually lead to cardiac or renal complications such as endocarditis, rheumatic fever, and glomerulonephritis. It's highly contagious, and inhalation transferred by inhalation or direct contamination with the droplets. And that's the strep that I'm talking about. These clients will have a very sore throat. They'll have dysphagia, so it hurts to swallow, fever, headache. They may have a white or exudative patch over the tonsils, and the glands might also be swollen. We can do a throat culture or antibiotic treatment. With pharyngitis, it's important to encourage the client to keep their throat moist. They need to keep those fluids going. Uh, if they keep the throat moist, just small sips of fluids, even though it hurts to swallow, it will actually be easier for them to swallow. Sometimes drinking or sipping on cold things such as popsicles or ice chips can be very beneficial to help keep those tissues moist. Tonsillitis and adenoiditis is a really common issue in children. This is basically a primary infection in the tonsils or the adenoids, or it could be a secondary infection from upper respiratory infections. With chronic tonsillar infections, we have partial airway obstruction. We may also have chronic adenoidal infections and otitis media. That all comes about from these infections. These clients also have a sore throat. They have difficulty or pain with swallowing. They may have fever, malaise, enlarged adenoids, nasal obstruction, or snoring. We're going to treat it with antibiotic therapy, analgesics, and saline gargles. Surgically, we can do a T&A, a tonsillectomy and adenoidectomy, but this is for clients that have repeated infections, sleep disorders, chronic tonsil enlargement, repeated otitis media, or hearing loss. Nursing-wise, postoperative care is going to include an ice collar where we just basically wrap ice around their throat to help reduce edema and to help deal with pain. We're going to monitor vital signs, do the warm saline gargles, ice chips, cold fluids, and monitor for bleeding. Again, we would watch for repetitive swallowing, as this can be an indication that they are bleeding, but it's just going straight down the throat. After a client undergoes surgery to the upper respiratory tract, the nurse should monitor the client for the patent airway is going to be the most important thing to monitor. Laryngitis is an inflammation and swelling of the mucous membranes around the larynx. Causes include the upper respiratory infection, excessive use of the voice, allergies, and smoking. These clients often cannot speak above a whisper, or they may have aphonia, which A meaning absence of, complete loss of the voice, the throat irritation, and they may have a dry, non-productive cough. Now, if that hoarseness lasts longer than 2 weeks, they need to have this investigated. Uh, Hoarseness, prolonged persistent hoarseness is going to be an indication of laryngeal cancer. We treat it by encouraging voice rest, treatment or removal of the cause, and antibiotic therapy if the cause might be bacterial. And of course, we always encourage smoking cessation. Obstructive sleep apnea. Now, this is not one of your core curriculum issues, but this is a very common issue, and I wanted to make sure that you had a little foundational knowledge. This is basically recurrent and frequent episodes of upper airway obstruction and reduced ventilation. It can be central sleep apnea, where we have a failure of the brain to signal the body to breathe, obstructive, or complex, which is a combination. These clients often snore very loudly, and they'll have cessation of their breathing for at least 10 seconds throughout their sleep cycles. They'll awaken suddenly, maybe not fully awake, but they will arouse enough that they take a breath, and often they have a loud snort with that. They have daytime fatigue, morning headache, an inability to concentrate, and forgetfulness, a sore throat, enuresis, which is urination at night, and erectile dysfunction. We diagnose obstructive sleep apnea with polysomnography. And this can be done at an inpatient type atmosphere where you go in and you're attached to a multitude of monitors, or they also now have home studies. And those home studies can be sensitive enough to be able to diagnose obstructive sleep apnea. Risk factors for sleep apnea include obesity, cigarette smoking, older age, and having obstructive sleep apnea increases the client's risk for hypertension and stroke. We treat it by encouraging the client to lose weight, smoking cessation, elimination of alcohol, or at least limit alcohol use close to bedtime. And if you think about it, A lot of times obstructive sleep apnea comes about because of the relaxation of the structures in the upper airway. So if you give them alcohol, we're encouraging relaxation of those structures. So the risk of obstruction is even greater. We can encourage these clients to use special pillows. We can also use continuous positive pressure airway pressure, which is the CPAP, or we can do the bilevel positive airway pressure, or the BiPAP. Surgically, there are procedures that can be done, but these often don't have the results that we would hope for, so they're kind of a last-ditch effort. In other words, they're not as successful as you would think. Nurses need to provide reassurance, adequate instruction, explanations, maybe self-help groups and counseling. Laryngeal cancer is usually caused by some type of carcinogen, frequently tobacco, alcohol, airway pollutants, chronic laryngitis, or acid reflux. These clients may have a persistent, progressive hoarseness, swelling or a lump in their throat or neck, dysphagia, and weight loss. We can diagnose by using a laryngoscopy, biopsy, or a scan. Surgically, we can do laryngectomy, and often that would be used in conjunction with chemotherapy or radiation therapy. We should always assess the client for hoarseness, for dysphagia, dyspnea, burning in their throat, their anxiety level and coping strategies, their ability to communicate, and aspiration prevention. If they do have a laryngectomy, they will not be able to speak any longer. So they may have to develop some other type of communication. This laryngeal speech after a laryngectomy, excuse me, may require esophageal speech, where we have regurgitation of swallowed air in formation of words with the lips. We can do the artificial larynx, which is that electric acoustical device that basically has a throat vibrator held against the neck, and then it can help project sounds into the mouth. We can also do the tracheoesophageal puncture, which is a surgical insertion of a prosthesis. Now, there's a lot of psychosocial issues with this. We need to assess the client for social isolation, promotes positive self-esteem, and encourage social relationships, and provide support services. A tracheotomy is a surgical procedure that makes an opening into the trachea. A tracheostomy is going to be a surgical opening into the trachea where we put a tracheostomy or a laryngectomy tube. This opening could be temporary or it could be permanent. It's very important that we monitor the client's vital sounds, vital signs, their breath sounds, assess their skin color, their level of consciousness, and their mental status, airway patency, and we also need to monitor the stoma and secretions. And I will encourage you that people that have a tracheostomy do not have any control over the secretions unlike a person who does not have a tracheostomy. So if they begin coughing, a lot of times the secretions literally will come flying out of that tracheostomy. So I always encourage you to stand to the side and just be aware if they start coughing and you hear the secretions roiling around, to be aware that the client has no control and we need to catch them with a tissue or at least stand out of the way. We may need to provide suctioning to remove the secretions and, of course, elevate the head of the bed. Endotracheal intubation and mechanical ventilation would be used when there are respiratory difficulties or the client has an inability to maintain an open airway. Mechanical ventilation, we can use negative pressure and positive pressure. With nursing management, we have to monitor vital signs, the arterial blood gases, their oxygen saturation, their mental status, confusion, agitation, auscultation of the lungs, suctioning of the lungs and the airway, humidification, communication, and the majority of the clients that have an endotracheal tube placed and are on mechanical ventilation will require sedation. And your post-test.